Hello, I'm Tore Laerdal.
And I'm Cansu Akarsu.
And we're delighted to take you through a webinar presentation we gave to the Breastfeeding Innovation team on June 15 on the theme of helping babies grow. So this presentation has 4 parts. We're starting with our journey from helping babies breed to helping babies grow. Then we're commenting on the small baby's journey to breastfeeding. We'll talk about the nifty collaboration project, and we'll end with some comments on making innovation happen. This presentation is coming from Laerdal Global Health, which is a not-for-profit company set up to help save 400,000 more lives per year by 2020. We feel this is fully possible by helping train and equip over 1 million birth attendants to become more efficient lifesavers, by introducing disruptive innovations, and by working closely with partners to implement programs. Helping Babies Breed was introduced in 2010 and has by now reached over 350,000 birth attendants in 77 countries. Studies in Tanzania, Uganda, and Nepal show that when well implemented, this program can reduce early mortality by as much as 50%. Why has this program been successful? It deals with the essential steps only. It uses hands-on simulation-based training methodology. It has a peer training model. It uses highly affordable tools. It's locally owned for its implementation and is broadly endorsed. Helping Babies Breed has now become Helping Babies Survive. In addition to the Helping Babies Breed program, which deals with about 20% of the mortality, 28 first days in the newborn period, essential care for every baby and essential care for small babies cover the 2 other main causes of death in the newborn period, and altogether these 3 programs cover 80% of the newborn mortality causes. Breastfeeding and skin-to-skin care is an essential part of the 2 new programs. The Helping Babies Grow bundle consists of several components: the Mama Breast milk expression trainer, the Nifty Cup for feeding, Preemie Natalie for gastric tube insertion and for feeding training, and the Care Plus KMC wrap for prolonged skin-to-skin care. Cansu will show in this video how this works. Here you see the Mama Breast expression of milk, the feeding with a cup, and the application of the Care Plus KMC wrap. Over to Cansu to take us through the small baby's breastfeeding journey.
Hello everyone. My role at Laerdal Global Health is to do user-centered design, and I will now take you to the backstage of how some of the products that Tore mentioned have been developed. So let's immediately move to a KMC ward in Malawi. Here is where we have tested and developed Care Plus wrap, and it was during that time when we realized that we could learn more about the breastfeeding and the infection protection part of kangaroo mother care. So we decided to start a learning process around these 2 topics. So what was our title for this learning process? It was, how might we help provide breast milk for babies who have not developed a suckling reflex? Looking specifically on babies who have trouble breastfeeding after birth. One of the design methods we used during this learning process was to start with the literature research. We read a lot about different guidelines and the evidence-based research. A second thing was to do co-creation workshops together with experts and users. Another one, and this is probably the most important, is to go on immersion trips. We went on trips through Tanzania, Malawi, Rwanda, Nepal, and India. And these were sometimes conducted by our design team, sometimes it was one day added to our implementation team's existing trips. Another method we used was to do crowdsourcing the information. So we kept in touch with the people we have met during these immersion trips, and we used WhatsApp and Facebook to reach them and to learn more about how we can develop new solutions. From the learnings we had from the immersion trips, we had to break down a mother's journey of feeding into small steps, and we used storyboarding techniques in order to identify all the challenges she would face during a feeding journey. And then we took out some of these needs and we mapped them out. So this is a map that you see of the needs from both the healthcare personnel's perspective and the mother's perspective. So this is a big canvas report that we developed after doing this learning, and I will now take you through this in a more systematic way. So let's look at some of the opportunities and needs that we have pointed out from the small baby's breastfeeding journey. And here, let's first look at the Milky Way. So Milky Way is the process of baby from the birth until latching on the breast. It starts with skin to skin, and then the baby smells the breast, the baby touches the breast, and the baby licks some milk, and the baby then finally latches. So this is the same for every healthy newborn baby. What happens with small babies is that the process that could normally take half an hour to some hours takes several weeks, because these babies do not have a suckling reflex. So how do we feed these babies during the few weeks until they can successfully latch on the breast? It consists of several steps. The first one is to be able to get breast milk from the mother. The second is to find out the right feeding amount and frequency for the specific baby. And the third is to find the feeding method. And here we looked at NG tube feeding and cup and spoon feeding methods. The fourth one is to practice a transition to breast, doing skin to skin and having the baby given a chance on the breast at different feeding times. And to regulate all this, to regulate the feeding amount and frequency, especially looking at the growth of the baby. So we hope and believe that if we can crack this cycle, then there's a better chance for the small babies to go to exclusive breastfeeding. So now we will go through each step and look at some of the experiences and the challenges that mothers and babies face, and we will point out some of the opportunities we have identified. Starting with obtaining breast milk. When we started looking into obtaining breast milk, we discovered different ways of doing hand expression and taking milk out, but also different devices and the times that the milk is expressed. And this is actually divided into two. During the first few days, the urgency of taking the milk and the content of the milk is very different than during the first few weeks. So here it is quite important that the breastfeeding is initiated within the first hour, but how do you establish a breast milk production and feed the baby with colostrum without the normal stimulation of the baby? The answer is early stimulation of the breast. If the baby is not there, then the health worker is there or should be there to educate the mother on how to stimulate the breast and take the colostrum by doing hand expression. When it comes to the first few weeks, of course, the content of the milk is much different. And here, if we look at a healthy term baby's breastfeeding, then the baby both compresses and vacuums the milk out. But when you look at pumping or hand expression, we are doing either vacuuming or compressing. And we also learned that any kind of expression of breast milk actually should again start with stimulation. So here, we found out that there was quite a lot of opportunity in improving the effectiveness of hand expression methods, especially the training of a correct hand expression. Now let's move forward to feeding amount and frequency. Here you will see different ways that are used to communicate the mother on the feeding times and the feeding volumes. And of course, you can see the different devices that are necessary to do this step. Of course, there is a recommended feeding amount and frequency, but there's also a mother's perception of what the baby needs. So usually the mother has an idea that the baby needs more than the baby actually needs. And this leads to either overfeeding the baby, or if the mother does not have enough breast milk, it leads to feeding the baby with other substances. So it's quite important to communicate that the baby's need might not be as much as the mother thinks. Another topic that is challenging is to understand baby's hunger and satiety cues. So especially with cup feeding, when the baby can give more clues about when and how much the baby can take milk, then this is quite important to learn as a skill. One more challenge was that there's an extra device usually needed for measuring the milk, which of course leads to milk moving from one device to another, and this is of course a risk of contamination. So when we look at the feeding amount and regulating that needs to be done based on the growth monitoring, which is an element we'll touch in the next slides. And we also saw that the guidelines around feeding amount and frequency were not comprehensive enough, and they were difficult to apply in real life. So when we looked at different KMC wards, we saw that people were having different charts in different places. So this is also an invitation, of course, for everyone to join these opportunities, and one of them is to do more research on feeding amount and frequencies. And another one that was prioritized was training on hunger and satiety cues and giving baby more chance to participate in adjusting the amount and frequency of feeding. So let's say we have found out how much the baby needs and it's a feeding time. How do we decide on the feeding method? First step is to give the baby a chance on the breast, to position the baby on the breast. But when we see that the baby is not latching, the breathing, swallowing and suckling has to be assessed to decide whether the baby needs NG tube feeding or cup or spoon feeding. So what was kind of important that we found out was actually 83% of preterms are late or moderate preterms. So these are a potential group who are more likely stable at birth, and they may not need NG tube feeding, and they can potentially benefit from cup and spoon feeding until they have a transition to the breast. So now we are going to focus more on this group of babies. And it was quite important as an opportunity to help health workers and mothers to classify a baby for finding the right method of feeding. So this is a whole picture of different cups that we have actually gathered from different parts of the world. You will see that there are tiny cups, there are larger cups, there is paladi, and there are different sizes of spoons as well. The main challenge we see here is that what is recommended as cup and spoon feeding is interpreted differently in different locations. So let's look at some of the specific challenges that cup and spoon feeding practices have. There is not a standard size of a cup and spoon that is developed for preterm babies or low-weight babies. And because of the nature of these devices, sometimes the mother is pouring milk into an inactive baby's mouth. And we also saw that the baby is sometimes kept too horizontal, and in general the pace of feeding was not really controlled by the baby. At the same time, you would see a mother being impatient because the baby is taking a lot of breaks during feeding. And another, of course, sometimes the baby was not even kept warm while feeding. So we found an opportunity here to improve alternative oral feeding to fit the needs of small babies. And we'll get back to this when we talk about the Nifty Feeding Cup collaboration. But let's move forward with our chart. The fourth is to do a transition to breast. So after or before a feeding session, it is quite important to give the chance for the baby to have skin to skin and also to have a chance to practice suckling on the breast. And here we saw that this is a quite challenging period and it may require a combined feeding methods. For instance, sometimes the baby could feed from the breast and then this could be topped up with cup and spoon feeding when the baby is not taking enough from the breast. And the whole topic of transition to breast is an area which is not really emphasized enough in guidelines. Then we see so many mothers getting discharged from hospital before the baby can latch on the breast. And when they go home, there is a much reduction in skin to skin at home. And this is of course not helping with transition. So let's imagine that we are trying to help the mother and the baby to have a transition. And during this period, the biggest concern of the mother is to know how much the baby took from the breast. So only by kind of estimating how much the baby took from the breast, then they can know how much more the baby needs. The way we can help the mothers and health workers identify if the baby is having enough milk is, of course, looking at the urine output, the weight gain, the different parameters that also have to be taught to the mother and health worker. So one of the opportunities is to improve the guidelines to focus more on transition to breast and to develop a step-by-step approach to ensure that these babies have a successful transition to the breast. Now let's look at the growth monitoring of the baby. Here we try to understand how the baby thrives, but also does a weight gain during the period and how this weight change can be used to adjust the feeding amount and frequency. Here are different growth charts, different methods that are used for weighing the baby, and also all the steps that are taken as the baby is put on a scale and taken out. And we can divide growth monitoring into two steps. During the first 2 weeks, the baby can lose up to 10% of the body weight. And in the second week, the baby should be gaining back the birth weight again. But this is quite actually an important period because it's a period when we lose many of these babies. So monitoring the weight loss and actually preventing it to reach 10% is an opportunity, because when we identify, okay, the baby is not doing well, then we can correct the feeding method, and also perhaps this baby may need to be treated because of an illness. And we see that many of the growth charts do not really have a zooming in on the first 2 weeks. First 2 weeks are not prioritized visually. So it's quite important to find an easy way of tracking a weight loss so that we prevent it from reaching 10%. After the second week, then we hopefully will see a weight gain in the baby. And we found that in places where actually the weight is measured, there was a lack of finding the weight gain. So we found that actually by monitoring the weekly weight gain, you can adjust feeding method. But if you're only taking the weight, that is giving you less information on how to improve the feeding. So here, the opportunity is calling for ways to regulate this by looking at a difference in weight, not an absolute weight. So after growth monitoring and after finding how to improve the different feeding methods, then we have a better chance to go to exclusive breastfeeding. And this is quite important because the small babies are the group that is having the most challenging time to reach to the 6 months exclusive breastfeeding. And by providing this support mechanism, we have a better chance to help them latch on the breast and do exclusive breastfeeding. And back to the more complicated board we have, which you can actually reach from the link above. The alternative oral feeding was popping up as the lowest hanging opportunity with the highest life-saving potential. Now this leads us to how we did the Nifty Feeding Cup collaboration. From the opportunity, we wrote a design brief, and the topic was, how might we improve alternative oral feeding for feeding small infants correctly? And when we say alternative oral feeding, this is staying under the umbrella of WHO recommended cup and spoon feeding. And when we mean correctly, we mean allowing the baby to actively take the milk, holding the baby semi-upright, not horizontally, and helping the parents or the health workers track the volume of milk. Defining a cup and spoon to fit the needs of preterm and low-weight babies was a topic we had during a workshop. And the results were that the cup needs to facilitate the baby's active participation, and the cup needs to provide milk to the baby's mouth at all times, both to stimulate the baby and to have the baby actively take the milk from there. And there was a need to provide graduations, to give more guidance on measuring milk volumes, and of course easy to clean and reusable. And another topic was to improve the whole training around cup and spoon feeding by assessing which preterms are qualified for this type of feeding. Now we will see a video of how we moved from need finding to developing some concepts and then collaborating with the Nifty Cup team. As you saw in the video, we started with prototyping and sketching different ideas. Then we moved forward with taking these ideas to the users and testing them with the babies. Here is a map of how we did the iterative prototyping process. So it starts with a lot of low fidelity prototypes. Then we focus some of the ones which are actually working fine. And then we generate alternatives of the different concepts that receive positive feedback from the field. So it moves from big number on low fidelity to small numbers on high fidelity. It was during that process when we meet the Nifty team in Seattle. So Nifty team consisted of PATH, Seattle Children's Hospital, and the University of Washington. And we met the group of experts and we tried to find how can we make sure the Nifty Feeding Cup can fit the needs of small babies. So now you'll see an interview from our launch at Women Deliver.
We always work with sort of a technology focus, a commercialization focus, and then a global health focus. And so we were able to think about all the different needs that a cup like this might feel. And whereas it was really coming from sort of that craniofacial cleft palate, lip palate domain, we really saw a huge need for a cup like this for preterm infants. And we know that right now in global health, there's a lot of emphasis and focus on preterm infants, and there are 15 million of them that are born every year, and so there's really a huge gap there in terms of feeding technologies that can be used in community or in hospital settings, but that are very simple to use, easy to clean, and hopefully inexpensive. So at PATH, we always work with an industry partner. That's one of the things that we've done from the very beginning, and we have a long shared history with Laerdal, and so we were really thrilled when Laerdal actually came to us and asked us initially about the cup and, you know, adding it to your suite of essential care for every baby and essential care for sick baby curricula. So, you know, really it's another win-win situation for everybody. We were able to provide a lot of the design files and the design input to you at Laerdal, and then your design team also made their own additions.
Because I think it has been really fantastic that you were able to visit our site at Sri Ramachandra University and also do your own testing in Pune to kind of combine all, as well as Laerdal's testing in Tanzania and other locations, to really get a holistic picture, which is something that's a lot harder to do in research. Yes. And Laerdal has that kind of nimbleness and flexibility with which to go into places and really make sure the design is optimized.
Nifty is a feeding cup fitting the needs for small babies. It has a small reservoir in the front. The milk can be put towards there and provided to the baby's mouth at all times. And you saw in the video that the baby can actively take the milk from the reservoir. Let's go back to our map. Looking at the opportunities we listed earlier, we can position Nifty Feeding Cup and premenatally for alternative oral feeding and the training of NG tube feeding, Mama Breast for obtaining breast milk, Care Plus for transition to breast, and Mama Breast and Preemie again to practice different breastfeeding positions. And we welcome all of you to join to solve this puzzle, and we welcome all of you to take part in the opportunities that we listed earlier. By doing that, we really hope that we can help these small babies have a transition to breast and move to 6 months exclusive breastfeeding.
So now, let's end with a few comments on making innovation happen. Innovation is a word we're all talking about, and your group is called the Breastfeeding Innovation Team. But what is innovation? So far, I think we've been presenting some inventions, but for them to be innovation, they need to be widely implemented and have real impact, because innovation, in our view, is all about impact. This can also be presented in the context of the new Sustainable Development Goals. We see that number 3 deals with good health and well-being, number 4 quality education, number 9 industry's participation to make innovation happen, and the most important of them all, number 17, partnerships for the goals. Because efficient implementation requires collaboration, as we see in the Survive and Thrive Global Development Alliance that is widely endorsed by implementing partners and also the global professional associations. So the Helping Babies Grow bundle comprises these products that Jansu has presented, but very much also the educational programs and a series of breastfeeding support videos developed by Global Health Media with funding from Laerdal Foundation. Life-saving needs to be fun to learn and to remember. Breastfeeding can save many, many lives if well implemented. Let's collaborate to do so, and we very much invite your comments to this presentation. Thank you.